At the outset, on behalf of Bombay Orthopaedic Society and the organizing and the scientific committee, I, Dr. Abhijit Kale and Dr. Ashish Fadnis are delighted to welcome all of you, teachers, friends, residents, fellows and trade partners to Mumbai for the 57th annual conference of Bombay Orthopaedic Society, that's Wiroc Max 2022. May I ask the Honorable President of Bombay Orthopaedic Society, Dr. Rajesh Gandhi, and the Honorable Secretary of the Bombay Orthopaedic Society, Dr. Neeraj Bidlani, to join me on stage. Taking a clue from ancient Sanskrit shlok, Annadanam Paramdanam Vidyadanam Ataha Param, Annena Shanikaha Truptihi Yavat Jivanam Cha Vidyaya. The binding force for all of us today is Vidyadan. May I call upon the Honorable Secretary of Bombay Orthopaedics, Dr. Neeraj Bidlani, to take over.
Good morning, everyone. I welcome you all to Wiroc Maximum 22. I invite our beloved President, Dr. Rajesh Gandhi, to come to the dais and declare the conference open.
Good morning. Good morning, everybody. May I invite Executive Council of Bombay Orthopaedic Society to please come on the stage.
We would take great pleasure in inviting IOA President Dr. Atul Srivastav to kindly join us on the stage. We also take great pleasure in inviting IOA President-elect Dr. Ram Chadda to kindly join us on stage. And we also invite Dr. Rajendra Abhyankar, MOA President, to kindly join us on stage. Thank you everyone for being present at the inauguration. I hand over to Dr. Rajesh Gandhi to deliver the inaugural address.
Good morning. We dreamt big. My respected teachers, esteemed seniors, and dear colleagues. We dreamt of making the Wiroc Max 2022 biggest of all, in terms of academics and in terms of the event. Learning has no patent. Here is the platform where we contribute and we learn. Difficulties in the life do not come to destroy you, but to help you realize your hidden potential. Let the difficulties know that you are difficult, not easy to be discouraged or defeated. Organizing the event at Geo World Convention Center was a monumental task. I was told it is difficult. Team Wiroc slept with their dreams and woke up with the commitments to follow up those dreams. The efforts by the team is stupendous. And you have seen the result of the same. You have seen the results of the same, the event, how it is shaped. No one succeeds alone. No one. Our theme is motivate, innovate, integrate. We worked our way towards the goal. We tried to incorporate the newer ideas and hope we have succeeded in delivering the same. None of us will go hungry. Academically, I thank everybody for being present at the inaugural function. Jai Hind. May I request everybody to get up and we will do the lamp lighting ceremony, please.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो
Thanks to the Honorable President, sir, for those encouraging words. The Bombay Orthopaedic Society has the highest regards for your contributions to health and the welfare of mankind. Orthopedic issues are complex with important ramifications for our nation and our future. Today, Bombay Orthopaedic Society is recognized as a role model for other medical associations, and Wiroc is regarded as a benchmark for all the orthopedic conferences in this part of the world. Today we stand on the shoulders of giants, and it has been a continuous, persistent, and laborious efforts of our senior founding members which has borne fruits which we savor today. As we race into the future, academic meetings will become the focus of expectations greater than even before. The nation will look to them to carry on our tradition of achievement and success. May this conference serve as a forum for exchange of scientific information which will promote and upgrade the quality of research in our country. The venue of this conference is renowned not only for its grandiosity, but also for its rich Indian traditional and cultural heritage. Myself, Dr. Abhijit Kale, and my colleague, Dr. Ashish Fadnis, are humbled to stand before you as the organizing secretary and thank the members of this society for the trust and confidence in bestowing this distinct privilege upon us. As we celebrate 57 years of existence of Bombay Orthopaedic Society, our society has progressed despite adversities that have come along its way. The success of this conference is not only the responsibility of the scientific and the organizing committee, but also of all the participating delegates and the fellow BOS members. I conclude with a quote, "Life is short, heights are great to scale. Carve your name on everyone's lips and the world will tell your tale. Long live BOS and may Wiroc Max rocks. Jai Hind." May I request all to...
With these concluding remarks, may I declare the conference open and Jai Hind. May I request everybody to please stand up for the national anthem. Jai. I thank delegates to be present over here. Now we start with the plenary sessions.
Thank you. Thank you, the leaders of the Bombay Orthopaedic Society. This is truly a league of extraordinary gentlemen who brought us to this stage. It's been a fantastic start to Wiroc Max. It's indeed been a Wiroc Max, and you provided us with a lot of entertainment, a lot of academics. On behalf of the delegates, we thank you for all the efforts you guys have put in the last 6 months. And once again, thank you so much. So going ahead with the plenary sessions for day number 2 in Hall A, we move on with the series of eponymous lectures. And the RJ Katrak oration is synonymous with Wiroc since time immemorial. Dr. Katrak was indeed a torchbearer for orthopedics in Western India and all of India and maybe in the world. And it is only our honor to have the first eponymous lecture to be named after him. Of course, the lecturer for the Katrak oration has to have a standing that matches with the man himself. And we are very, very fortunate to have a person who's not only put perspiration, but also inspired many. Dr. Sanjay Agarwala will be introduced by the convener of the session, our president. But I must say that he's been a teacher to many, and he is one of the true orthopedic surgeons who does everything from spine, hip, arthroscopy, and it's indeed a great pleasure to have him as the Katrak orator. To roll in this session, may I invite our esteemed, honorable, friendly, most affable, always smiling President, Rajesh Gandhi, sir.
May I invite Dr. Sanjay Agarwala. Please come on the stage, sir. Dr. Sanjay Agarwala needs no introduction. He is the Director, Professional Services and Head of the Orthopaedics at Hinduja Hospital. He is also a visiting consultant at Bridge Candy Hospital in Mumbai. He is the founder, trustee and the past president of ISHQ. He has over 85 publications in peer-reviewed journals, and he is active contributor in the field of research in orthopedics. His research has established a made-in-India Atmanirbhar solution using bisphosphonates successfully for crippling and painful disease of AVN. He has over 37 years of successful practice in adult reconstructive surgery of the joint arthroplasty and complex trauma. He has mentored many postgraduate students who has risen to great heights. Dr. Sanjay Agarwala has successfully blended the best of the East and the West to bring world-class care for the benefits of the Indian patients by his large contribution to academics and basic research. The years of experience, clinical knowledge, and surgical excellence have defined his successful career, and he continues to give his best to the society. I request him to deliver the R.J. Katrak oration. Sir, please come. Thank you, sir.
Earlier on, when I had asked Rajesh, who do I thank? He said, sir, Bombay Orthopaedic Society. So with that, I thank Bombay Orthopaedic Society for having selected me 2 years ago for the next group of BOS members to have agreed, and for the present BOS executive to have me on stage today. The Katrak oration, as you know, is the foremost eponymous lecture that is given in the Wiroc.
At the Katrak oration, Dr. Sanjay Agarwal of Hinduja Hospital. Dr. Agarwal, thank you for being with us, and let's say a warm hello to everyone at Wiroc, the Western India Regional Orthopedic Conference, where you are giving this oration. Let's say a big hello to them at the start.
Hello, hello, I am here. The late Dr. R.J. Katrak was born in the 19th century. He serviced orthopedics in the 20th century, and today, in the 21st century, we still remember him. He was a general surgeon and then decided he would be an orthopedic surgeon. Went to do his MCH Orth in England in 1936, when general surgeons were actually rendering orthopedic services. Came back during the war, was at JJ Hospital, BJ Wadia Hospital, doing conservative rather than very aggressive pediatric orthopedic care. Went on to be at KEM and at Sion. An outstanding achievement for someone who visited 4 different hospitals in his lifetime. He was the founder president of the Bombay Orthopaedic Club, which then became the Bombay Orthopaedic Society, and the first Indian fellow of the British Orthopaedic Association. He was an outstanding teacher, is very clear. He was the teacher to Dr. A.K. Talwalkar, Dr. Ellen Vora, who I had the privilege of being registrar for 2 years during my MS. He had an outstanding memory, almost photographic. And Dr. K.T. Dholakia, who I worked with for 18 years when he would come to PD Hinduja Hospital. Dr. Dholakia would stay the night, rehearse the operation, and write the procedure on his hand. The fate of the patient was not in the hands of the patient. It was on the hands of Dr. K.T. Dholakia, and many of us who have worked with him and interacted with him know what an outstanding man he was, and Dr. R.J. Katrak was his teacher.
What drives you?
So what drives me? That's the whole idea of this R.J. Katrak oration. I think it's inspiration with perspiration. It's a winning combination, and as has already been explained, my journey, if I have seen further than others, it is by standing upon the shoulders of giants, a cliche. But truly, these were the giants I worked with. I was a house officer with Dr. R.M. Bansali. I had Dr. Pradhan and SKB, Dr. Bandare, as the vice or deputy honoraries at that time. I was a student of Dr. M.N. Shahane, and the only and first student of his who actually had the privilege and the occasion to work with him, because I was assigned to the Ellen Vora unit. Dr. Saraf, an outstanding man, he would say, "Beta, start karo, khatam mat karna." So I had a lot of surgical experience because of Dr. Saraf. And Dr. Ingalekar, Dr. Joshipura, Dr. Chauvel were the contemporary teachers of our times. And I think those were the shoulders on whom I stood. KM was, of course, the alma mater. I gathered a couple of first ranks, a couple of medals. But the turning point in my career was when I got the International Graduate Fellowship Award of the Rotary Foundation. I pipped a man no other than the current dean of Harvard University, Dr. Datar, and the two of us were the final contenders, and this must be the only time that Dr. Datar has ever been beaten by anyone. It was me. I went on to Oswestry in 1982 under Professor Brian O'Connor. In those days, there were only 6 professors in the entire UK. He was one of them. I went to Northwick Park Hospital in 84, worked with Leslie Kleneman, whose interest was foot, and later on, Leslie Kleneman became the professor of orthopedics at Liverpool. At Liverpool in 1985, I won the Norman Roberts Medal, which was generally not given to a lot of outsiders. And Norman Roberts himself was alive on the day that this was presented to me. I went to Johns Hopkins to do a fellowship with Schmeiser and Stoke-on-Trent in 1986 before returning to India, to the PD Hinduja Hospital, where I have been for the last 37 years. Breach Candy Hospital is where I also have an affiliation. And I think I'm a clinical scientist, a clinician and a scientist, because I have authored over 100 peer-reviewed papers. I'm not going to take you through my 100 papers, but I'll take you through papers that really matter and the ones that will work for you.
So every time I meet you, something good happens. Either my film becomes a hit or I get a nice film, so I'm hoping something else happens.
So wow, she said that some of her success was due to me. And these are the kind of privileges I've had working at the Hinduja Hospital. At Derby, I did hand surgery with Frank Burke, who took the mantle of the unit, which was started by Guy Pulvertaft. You will remember Pulvertaft sutures. And having done this hand surgery, I started using the surgical microscope for replantation surgeries and came back to India and started the replantation program at Hinduja Hospital. My interest took me to write papers in the British Journal of Plastic Surgery using nerve conduits. I used Goretex for nerve conduits successfully. However, the spine was what I was introduced to by Dr. M.N. Shahane, and my Harrington rod fixation paper, which was my thesis, also won the Masalawala Award at the Wiroc way back in 1982. Having worked with John Dove, I brought back to India the Hartzell rectangle fixation. Thereafter, the Hartzell rectangle was copied. I think Pitker was the first people who copied it for me. John Dove was very annoyed that I was having it copied, but that was the only way I could do segmental spinal fusion. But microlumbar discectomy, because I had an interest in the use of the surgical microscope, I brought to India. And in fact, I don't know if Dr. Ingalekar is here, but I was the invited speaker for his Asia Pacific at the Taj in 1987-89. When he asked me to talk about microlumbar discectomy, no one for either neurosurgery or spine was doing microlumbar discectomy at that time. Thanks to the largesse of my trustees, They bought me the holmium laser machine, almost £1 crore in those days, difficult to buy, and I was doing holmium YAG laser assisted disc decompression successfully under local anesthesia. But I think there is a reason why there is a phrase in English, pain in the back and pain in the spine. It never seems to go away. The good patients would do very, very well. The bad patients kept coming back to haunt you. And I decided I would do some trauma. And trauma is something that we all learned when I was at KEM and when I was in England and when we did the AO courses. We learned from our skills to do trauma.
So we can fix the damage.
And we were fixing the damage done. Recognizing that there were certain shortfalls and recognizing the need for some innovation, I realized that fixing distal radius fractures would be a great thing. This met with a certain degree of criticism from senior orthopedic surgeons stating that this was totally overkill. I had to publish it, and the only journal that would accept it in that time was the Bombay Hospital Journal. I published it to show that this was the way of the future for Colles fractures, and now it's virtually a standard of care. Patients, and you'll recognize this very old plate right in the beginning, and the patient was able to do this in 10 days' time. If he was a surgeon, or even if he was a taxi driver, this was the way forward for the treatment of Colles fracture. Patella fixation, 1% of all fractures that come to a busy trauma practice are patella fractures. That is the statistics. If you do the Mueller technique, the K-wire keeps backing out. I described the technique where I combined Schauwecker's figure of 8 with the Pryford, and essentially once you have the figure 8, the Pryford, you can add 1 or 2 wires more, the patient heals. And my colleagues at Hinduja Hospital have seen this again and again. Patients are walking within 1 day of the surgery, and there is no risk of the K-wire backing out. We were seeing a certain number of tender Achilles, and all these repairs would break down because of skin complications. I described in the Journal of Foot and Ankle Surgery in the Asia Pacific region how I would do a minimal access, and maybe I can show it to you here. I would come through the skin here, go back through the same skin incision, and cut the bridge with a 15-number blade or 11-number blade. So effectively now, I had a percutaneous technique in this portion, and therefore these wounds would do very, very well. We were dealing with atypical fractures again and again, and none of them because of my bisphosphonates. And there was a problem getting these to heal. And I suggested and published that vigorous endosteal reaming across fracture sites aids union. And let me show you this in a little expanded version. You can probably see here how there's a cloud of bone formation. You take the reamer 10 times across the fracture. This cloud then remains here and aids the healing, and therefore even these difficult fractures can heal better if you are electing to nail them, if you've done vigorous endosteal reaming in this portion. We published all this. Ankle fractures, particularly the fibula, if you try to do the Weber and Vassie anti-glide technique, the fracture shifts. Recognizing this, I started twisting the plate and published this in 2020, where I would twist the LCP, a strong plate, and put it across so that it would conform, and then the results were excellent. I don't think AO copied me, but simultaneously they were working on similar principles, and their new plate has got a twist in it. My use of medicines to get fractures to heal is legendary. I have also repurposed denosumab for recalcitrant bone healing, published in the BMJ, And any if you wonder what technique I use, you just need to put Agarwala in BMJ for recalcitrant bone healing and you'll find the paper.
Here. What is it?
Now, trauma clearly brought me
What
to
does it look like?
be able. So I treated people. She went on after this foot injury that she had, and they were all worried that she would never dance again. That was her career. She went on immediately after that to dance in the movie Devdas. Surgical management of arthritis was, of course, something that was of interest to me. So when I came back from England, I recognized that there was a place for a high tibial osteotomy, but the staple that we were using was very, very loose. I added and created the box osteotomy, where I had a ledge at the back and a ledge in front. When this closed along with the staple, this locked like a box, and this was a stable way of doing a high tibial osteotomy, a lateral closed wedge. The patients did well. When AO introduced their locking plates, I thought that was even a better way of holding the fracture, and I didn't need any plaster supports, etc. And these worked well as well. Soon after, I realized that the biplanar osteotomy of the AO, which was an open biplanar osteotomy, was an excellent way of doing high tibial osteotomies. And note the ledge that even they have preserved here. They have this ledge here, and that's the ledge which allows for greater contact and therefore greater stability of the high tibial osteotomy. So I'm not saying they copied me, but I think they were also working similarly on similar principles. And this kind of a patient did well. But like I said, I recognized that even though there was this box osteotomy, that was eponymous with my name, the open wedge osteotomy was better because it had better outcomes. In turn, when we became members of AISHK, I was a founding member, founding trustee, became president, I realized that we really needed to get our patients in and out faster. And Dr. Pachure is here. You'll remember we used to keep patients for 2 weeks in the early days when we were working with Dr. Dholakia, which was a great way for the patient to get confidence. But the average length of stay, the ALOS, was tremendously long. And all of us, I think, all over the country, working towards fast-track recovery. I published this some time ago. And what even Mogambo bhi khush ho gaya isse, patients were comfortable to go home on the second day. Preoperative or perioperative education and physiotherapy, of course, helped. Periarticular infiltration was helpful. We do adductor canal blocks along with the periarticular because then that works extremely well for the back of the knee, ice packs, prophylaxis, anticoagulants, DVD socks, and intermittent compression devices all the time with immediate mobilization, because I really believe DVT is a problem. So,
all of you are feeling much better now.
The common belief is that Indians don't get DVT. My work, and you notice the date, 2002, 2003, showed that DVT exists in Indian patients and can be prevented with prophylaxis. An issue that's not been recognized is that MRSA affects Indian patients. Methicillin-resistant Staphylococcus aureus. We published it. There is a prevalence, surprisingly, of MRSA. Screening prior to all elective surgery helps you identify it. 3 days of mupirocin in the nose and axilla clears the colonization. In fact, just 4 or 5 days ago, I had a total hip replacement, which I cancelled because he was methicillin-resistant Staph aureus isolated in his nose. Post-surgery, patients hate the staple removal. It hurts. Might hurt for only 1 minute, but it hurts. And a physical follow-up is required. I have a certain cohort of patients who come from outside of Bombay, even New Bombay, or maybe even Satara. Now, those kind of patients, they need to reach a doctor, and often their fear is when they go to their local doctor, he will say, "Jidhar karaya tha udhar jao." Sad, but it is true. I have introduced this concealed cosmetic closure for total knee replacement surgery, and it's a superior cosmetic healing. It has minimal complications and great satisfaction for the patient. Here's a hip replacement. About 8 days after surgery, he's come to my clinic. I am removing the dressing for the first time, and that's it. He could have gone to Dubai and done this. He could have had it done in Delhi, wherever he came from. This is the way to be, so that the patient does not have to worry about suture removal. Of course, now coming to replacements of hip and knee. I have been founder member of AISH, current trustee, past president. My greatest concern was that we would get patients who wanted hip and knee surgery. And we would tell all these patients, you can only sit on a chair. For the last 25 years, I've been offering all my patients this degree of mobility. I'm going to share some of this with you. I think the magic in our hands is when we can give normal joint function after replacement. And look at the population. Asia and Africa, that's 80% of the world. China, India, Southeast Asia, the Middle East, and Africa. These are the requirements. And this, after standard replacement surgery, we say is not allowed. Western culture requirements we claim is this. They kneel if they go to church. If they play golf, they need to be sitting like this. And should we be telling them that they have restricted movements? We've not done them any great favors. Mayo Clinic handout. Avoid crossing, twisting your legs. Avoid bending from your waist more than 90 degrees. Don't bring your knee up higher than your hip. Don't reach down to pull blankets when lying in bed. This is crippling. This is what I offer all my hip replacements, and I'll share how, and all my knee replacements, and I'll share how. And I think this is what we should, as surgeons, be offering our patients. There is an armamentarium, and just like Maki Farrar showed that large heads work, we have seen how the BHR, which I still think has place, how delta motion, great prosthesis, used to work. Unlike the ASR, great prosthesis did not work, but has been withdrawn because there must have been problems. But the principle of a large head is, of course, a great principle. And we published this, a retrospective analysis of our midterm results. And when Andy Murray needed a hip replacement, he opted for the large head BHR. So large heads would give this kind of range of movement, we understand. However, sometimes when the muscles are weak and you have a patient with polio or you have a patient with a TC fracture, you cannot expect someone to prevent him from doing things that he's done for the last 70 years of his life. You offer him a dual mobility. And we published about this dual mobility, how this is a great prosthesis. Evolutus is one of the companies, Stryker is another, and there are a whole lot of companies now offering it. It's available freely now in India. It's something to adopt. But the magic is in getting the same stability and function with a standard THR. And I test for impingement and free hip stability. I do an anterior approach, as most of you know. And does that work? Well, we check. And there are a whole lot of nuances to doing this. But if the patient has this degree of stability, This is the patient who can dance. And I asked Yogesh Patkar, who you've seen on ZTV, whether I could use his video from YouTube. He says, "Sahib, please do that." And this is what I did for him. This man is dancing and he's sitting on the floor like a normal person. This is the magic which is in the hands of all of you. Adapt
By God, this is a fact.
and do it. So, what Mayo Clinic has told the world, at my hands, doesn't matter. We can get them to get full range of movement. Along with Dr. Jhunjhunwala, Dr. Pachure and I, we wrote about this paper where we did revisions. Of course, we would be doing revisions because we were doing primary hips. When you have a trunnion and you want to preserve the prosthesis in the femur, you want to save the trunnion, and you can't be putting things like gauze pieces and things that will work. All you need is a Foley catheter. You roll it, it saves it, and you can get along and revise your acetabulum. We published this in the Annals of the Royal College of Surgeons of England. Likewise for total knees. I don't want to restrict their movements. Do I have something that I can use for the total knee? Yes, I do. In the quest for the high flex total knee, I started using the RPF. The problem with the RPF I found, and when I spoke to the designer surgeon, he said, "Sanjay, you should publish it." Challenged me to do it. I published it in the Journal of Arthroplasty. This is what was happening with the RPF. The patella clunk. Thereafter, the company changed the model, and finally they've withdrawn it, unfortunately. But clearly there were problems with that. I have been using the Smith & Nephew currently, that's the Oxinium. It gives me a great range. I have a PS, the high flex, the constraint.
Give me a second life when he did my knees.
And patients can get normal knees. Here's a patient who came to me with fixed flexion deformity, pre-op, day 1 of surgery, and I told you I do very fast mobilization, 2 weeks, and at 1 month. I have a patient who's come from a village. I can't expect this patient to use a commode. I have them get normal movements. Yet another patient with a knee replacement, and this I give to 99% of my patients for the last 25 years. Hips and knees with full movements.
That's the right way to do it.
And I think you all should also adapt and adopt the techniques which are required to get this kind of movement. Now we come to bisphosphonates, the avascular necrosis. I've been doing this for 25 years. Transient osteoporosis, spontaneous osteonecrosis, AVN in post-leukemia, AVN other than hip, and post-COVID AVN. Now, COVID is all around us. These are all the papers that have been spawned by my interest in managing AVN.
Give us your magic pills all the time.
And that's Helen saying, "Give us the magic pills." My 20-year study was published in 21 in the JBJS. And the most recent publication, which is waiting to be published and has been accepted by the American JBJS in September, is about COVID and AVN. And anyone who is practicing orthopedics in this lot has seen AVN after COVID 101%. I am going to show you how to treat this without surgery. I've been publishing since 2001. When I say publishing from 2001, believe me, I was working on it 5 years before that. You cannot publish, start today and publish tomorrow. So I've been doing this, like I said, for 25 years. We have multiple publications, and it has spawned a whole lot of publications over a period of time. If you have smartphones and you wish to take this protocol, I would recommend it. I'm going to show it to you again in about another 2 or 3 minutes. You need to give zoledronic acid once a year. You need to give alendronate in small doses. I had started by giving 10 milligrams, but the companies have withdrawn that. 70 milligrams is less absorbed. You need to give calcium and vitamin D, and let's look at the rationale. Why a combination of two bisphosphonates? Alendronate is efficacious. Publications, look at our publication number 4, 2005. Publication 5, 2006. I published in 2001. The fact of the matter is that the effect of alendronate starts only after 12 weeks, up to 1 year. A patient who's in pain is not going to wait. The reason is alendronate at the best of times is only absorbed by 2%. So if pain improvement is late, patient is going to withdraw from your treatment and there will be decreased compliance. In 2006, 5 years after my publication, 2010, people used only intravenous bisphosphonates and showed that it was not effective. You would get early blood levels, some pain improvement, but it didn't work. Of course it wouldn't work. You're not treating osteoporosis, you're treating an acute disease. In 2002, there was this scientific paper which showed that resorption of necrotic bone is prevented in rat animals by doses which are 4 to 50 times higher than for osteoporosis. You cannot treat AVN with the same dose that you would treat osteoporosis. We recognized that edema was settling down, and in 2019 I published the transient osteoporosis of the hip. You have seen these cases, extremely painful. Some even opt for surgery. At 4 months, disappeared after you use bisphosphonates. Yet another case. I don't want to take you through multiple cases, but this is proved by literature and my publications. SPONK, spontaneous osteonecrosis of the knee. Same thing. At presentation and 4 months. I was in Belgium and they were operating a patient of SPONK because the patient had so much pain. If they had done my treatment and waited maybe 6 weeks, the patient would have resolved. This is confirmatory evidence that you can see in these publications. So our rationale is you give zoledronic acid, which gives you early blood levels, pain relief because it reduces edema. You give oral alendronate, prevents collapse. Combined therapy, the treatment protocol for those of you who didn't get a chance to take this picture. Give this will work. The natural history of AVN is 3 years. You need to give this for 3 years unless you're doing multiple MRIs and patient is well. You can stop it earlier. And the established safety of bisphosphonate is 3 years. So I have repurposed this drug. The drug repurposing is the practice of finding novel therapeutic indications for existing approved drugs. Now, these are just some of the examples. There are hundreds of drugs which have been repurposed. I grew up taking aspirin for my fevers when I was a child. Chloroquine. You treat malaria with 4-stat-2 after 6 hours, 1 BD for 2 days. We all know that. But when you use chloroquine for rheumatoid arthritis, the dose is different. Same thing with bisphosphonates for AVN, SPONK, and transient osteoporosis. We have repurposed denosumab for recalcitrant bone healing when you have well-fixed fractures. And look at this. Not healing, 9 months healing. You can see how this callus is formed with the use of denosumab in the right doses. Coming back to AVN, this is just some illustrative examples. Stage 2, bilateral, look at him at 4 years, doing well. Case of stage 3, almost stage 4. I mean, there's a little bit of arthritis, you could say. At presentation, at 3 years, at 12 years, we've avoided surgery for this patient. I think I've done him a service. And this is what is critical. Whether you're drilling it, you're doing forage, whether you're doing stem cells, or whether you're doing platelets, can you assure 98% in stage 1, 92% in stage 2, and 77% in stage 3? If the answer is no, then you are doing a disservice by offering that patient surgery. And this is all published data. You can check it up, 15 publications. It's all there in that. And I've not seen any case of atypical fractures and osteonecrosis because we confine it for 3 years. I think I've rewritten the chapter of management of AVN. AVN in leukemia. You have acute lymphoblastic anemia in very, very small children. Young children. Would you be offering these patients a crippled life, or would you offer them a total hip replacement? I think at 4 years, if the patient can do this, I think she's doing very well.
और अब मैं खेलने जाता हूँ, क्रिकेट खेलने जाता हूँ, फुटबॉल खेलने जाता हूँ, वॉलीबॉल खेलने जाता हूँ, दौड़ता हूँ, भागता हूँ.
It's a young child.
मेरे भाई के साथ.
As a hip replacement surgeon, should I have been telling him stay crippled till you are an adult? Or should I be saying get a hip replacement at that young age? This patient did well, and there he is. He is doing all activities that his brother can do. Avascular necrosis other than hip. Well, there it is. The talus, you can see it. Scaphoid, treated without surgery with bisphosphonates. Lunate, cane box, treated. And now we come to COVID. We are living with it. All of us are carrying masks. And we've seen this. I published this in BMJ very recently. And what we saw that in COVID, the mean dose of steroid in world literature was 2,000 milligrams. You can get AVN. Our study showed about 350 milligrams. And our study showed that it was happening much faster. So COVID is a disastrous disease for the bones. A low dose of steroid and a very early onset of AVN is happening. And this has been written up. We've been seeing this too in our patients. And again, what have we done? We've treated this medically. This has been accepted for publication by the American JBJS, should be in print in the next couple of weeks. I have a medical line of treatment successful for the management of AVN of these patients. And every single one of you who's practicing has seen COVID AVNs right now. And that's the kind of team I work with. I mean, huge team. In fact, there are a whole lot of people in the front row here who worked with me and worked along with me, and that's the kind of team I work with. And there you can see Dr. Bhalera, who was my teacher and he was my colleague in Hinduja, Dr. F.D. Dastur, Dr. Davar, Dr. Tempton Udwadia, Dr. V.R. Joshi, and that's my team. I work with a team. Team is everything. Zimbabwe, great player. Team let him down. The other chap, the team helped him. So he took the World Cup. I think 1% inspiration, but 99% perspiration, as Thomas Edison said. Work should be evidence-based all the time. Whatever is different must be studied, and novel treatments must be shared. That's what BOS is for, Wiroc is for, and what all of us as colleagues are for. Ideas, motivation, creativity. And you need to put in your hard work, the effort, and the determination to turn the ideas into reality so that they can be shared in forums like this or amongst your colleagues. The impossible we are doing all the time. You and I are doing these impossible things all the time. It's miracles that take a little longer. Thank you.
Truly motivational, Dr. Agarwala. And we are so proud to have you as one of us. We are so proud that you were the Katrak orator for this year. And we learned a lot from what you have learned. Thank you for sharing all those fantastic ideas. And it's indeed a great start to our series of eponymous lectures. Thank you again. Moving on, we move on to possibly the most exciting part of the morning, and that is the presidential guest lecture. Now, this lecture series could have gone to the president himself, but you know he's a humble man, and he decided that he should get some inspirational personalities to bring out the supermen amongst us. So we have three top-class speakers who have done seminal work on their own account, and you will be introduced to these speakers very soon. The presidential guest lecture hopes that at the end of this session, you go out inspired and do things that you never dreamt of doing. May I invite Dr. Rajesh Gandhi to convene this session and to bring our first rock star speaker on stage. He's a rock star surgeon himself. Dr. Anand Joshi, could you please escort Mr. Viren Rasquinha?
Think of them. Thank you. Okay.
I would request Dr. Anand Joshi to introduce Mr. Viren Rasquinha.
And I just have to do this. Morning. When Viren received an invite for this program, he was a bit worried. How would he be introduced to this elite group of orthopedic surgeons, some of whom who do not even know the difference between a hockey stick and a walking stick? So Viren, in all sincerity, sent his CV to us with attested mark sheets. So we now know that Viren is a Bandra boy who passed out from St. Stanislaus, did his BCom from the MMK college in Bandra. Now when you know that somebody is from Bandra, you know that he has to be good in sports, and also that there will be many Sandras from Bandras who will be after him. So coming from his mate who has been with him from the age of 13, playing both football and hockey with him, Viren was proficient in football as much as in hockey, and he would probably represented India either in football and hockey. And of course, like we all suspect, Viren had quite a female following from his early school days, back when he had a lot of hair on his head. Viren's wizardry with the hockey stick decided that he favored hockey over football, and we know what he has done in the field of hockey. He was a midfielder who is basically a multitasker. He needs to play both defense and offense. And the attributes for becoming a midfielder are you have to be fit, fast, and excellent acceleration. Now, although this sounds very simple, this is what M.M. Somaya, a triple Olympian by himself, has to say about Viren. As a midfielder, Viren was the link between defense and front line for his team. When the opposition attacked, he was like a shield. When his own team attacked, he would be the springboard for the front line, and he was an end-to-end player. He covered the ground from his own circle to the attacking circle. As a midfielder, he was the steam of the engine, and he did a selfless job without hogging the limelight. He was an exceptional leader in the middle of the pitch. Viren has a lot of laurels to his credit. He represented India in the 1990 Junior international hockey tournament in Hobart. He was part of the junior World Cup team. He has debuted in senior hockey from 2002 and was a member of the Indian team at the Olympics and also captained the Indian hockey team against Pakistan. What is most important, however, for an amateur athlete is achieving the highest accolade that one can hope for, and Viren is an Olympian. After playing 180 international games, Viren retired from international hockey and completed his MBA in 2009. He decided to give back to sports what sports had given him, and he worked effortlessly off the field as well, and currently he is the MD and CEO of the Olympic Gold Quest, a non-profit organization. All peers seem to have extremely high opinions about Viren. This is from Cedric D'Souza, who was the coach of the Indian hockey team. He says Viren was an extremely brainy player who used his intelligence and vision to be extremely effective on the field. As the CEO of OGQ, through his sporting knowledge and passion, he has ensured that athletes get the world's best trainers, facilities and exposure, which has put India on the map with so many medals. Viren's work on and off the field have been widely appreciated and acknowledged. He is a recipient of the Shiva Chhatrapati Award, the Arjuna Award. He is on the PMO's Olympic Preparation Task Force since 2006 after the Rio Olympics. And in 2017, he was named as one of the top 40 under 40 leaders in India by the Economic Times. So here we have Viren, hockey player, Arjuna Award winner par excellence, hockey player par excellence, and MD and CEO of the OGQ. Ladies and gentlemen, Viren Rasquinha.
Thank you, Doctor.
So that's to go forward. That's to go back. In case you want to point to something. Just give me 1 second.
Hi. Mic test. Yeah. Good morning, everyone. Thank you, Dr. Joshi, for such a kind introduction. It's very strange for me to see Dr. Joshi in formal clothes today. He's extremely formally dressed for me. I've only seen him in shorts generally. So, Dr. Joshi, good to see you wearing trousers today. First of all, thank you for inviting me over here. I'm a hockey player, so it's hard for me to stand in one position. So if you don't mind, I'm going to be walking around a little bit. Actually, Dr. Joshi told you all a little bit about my background growing up in Bandra. I actually came from a very conservative middle-class family, and you know how it was back in the days in the 80s and 90s, right? Mom was a doctor, by the way, so I have immense respect for all doctors. She was at Bandra Baba Hospital. She was a pediatrician over there for almost 35 years. And, as you see the crowds every single day lined up at Baba Hospital. And for me, doctors are gods. And so I'm tremendously honored to be here. Thank you, Dr. Gandhi, for inviting me. So mom was a doctor, dad was an engineer. And back in the 80s, 90s, if you had to be something in society, you had to become a doctor or an engineer. And I remember my parents being extremely strict with my eldest brother. My family was a sports-loving family, but no one really played any competitive sport. So parents were super strict with my eldest brother, and he eventually became an engineer. They were medium strict with my second brother. He was a very good football player, played at a very high level. Eventually, he also became an engineer. And I was the third and lucky one, because by the time I came along, my parents were not bothered at all. And that's how I could actually play hockey. I remember in 1996, the Atlanta Olympics, an Indian tennis player won a medal for India. Can anyone remember? Everyone? Leander. And I was a young teenager watching back at home on TV. And for me, actually, that was my moment of inspiration because like Leander, I wanted to play for India. Obviously, hockey was my sport, so I wanted to play hockey for India. I wanted to captain the Indian hockey team. I wanted to play at the Olympics. I wanted to win an Olympic medal. I was very lucky that my first 3 dreams got fulfilled. But the final one of actually winning an Olympic medal myself as a player, that remained unfulfilled. I played at Athens 2004, and I want to narrate a story from Athens 2004. So India was playing Australia in a very crucial league match. And as you know, like in cricket, Australia is a very strong team in hockey as well. India had to beat Australia to come to the semi-finals of Athens. For Australia, a draw was enough to go through. We were leading 1-0 in the first half. Australia equalized. They made it 1-1. That time, by the way, hockey was 2 halves of 35 minutes. Now the game has changed. It's become 4 quarters of 15 minutes each. In the second half, Dhanraj Pillai, you'll all know Dhanraj. Dhanraj got a yellow card. And India were down to 10 men for 10 minutes. Now, it's hard playing against Australia 11 versus 11. It's bordering on the impossible to keep up with them 10 versus 11 for 10 minutes. In that 10-minute period, Australia scored 2 goals. They were leading us 3-1. Dhanraj came back on the pitch. India made it 3-2. With 7 minutes left on the clock, India made it 3-all. But it was not enough. We had to find the winning goal. We were throwing the kitchen sink at Australia. With 4 minutes left on the clock, India hit the Australian post. The ball hit the post and came back into play. In the last 10 minutes, India had 5 penalty corners. But their goalkeeper had a great night. He saved everything we threw at them. With 52 seconds left on the clock, India had a free hit on top of the Australian D area. Except our goalkeeper, all 10 of us went on top to try and score. And then what happened in that last minute happened in a blur. Because in our urgency to try and score, one of us made a mistake. The Australians intercepted the ball in their D area. They counter-attacked us. And with 20 seconds left on the clock, Australia scored the winning goal that night. Australia won that match 4-3. That match finished, I remember, around 10 p.m. Athens time. I was crying on the sidelines till around 12 midnight. Because for me, it was around 7 years of effort that had gone into preparing for the Olympics. I was possibly in the best shape of my life, had worked as hard as I possibly could. And then that moment came and passed very quickly. I remember being very angry and frustrated, not because India lost, not because one of us made a mistake. I was just angry and frustrated at the system which I felt did not gear us well enough to handle the pressure against the best teams in the world when it really mattered. And at that highest level of sport, it's actually it boils down to the 1%ers. Because the difference between the best teams in the world and those who just participate are at that final mile when you have nothing left in the tank, when your heartbeat is literally at 200 beats a minute. You have nothing left, you have no strength. And then to summon somehow the energy, to somehow summon the concentration, to not make errors, because against the best teams in the world, you'll get maybe 1 or 2 chances in the game. If you don't miss it, if you miss it, you'll get punished with a goal behind you. That Australian men's hockey team went on to win the gold medal at Athens 2004 for the first time ever in their history. And India and me only participated. And that's why I say the difference between winning gold and maybe just participating can actually boil down to maybe 20 seconds on the clock or the width of a goal post. I retired, I played for a few years later, retired at a very early age. I went to do my MBA. And then I happened to meet two legends of Indian sport. I'm sure you'll all know them, Geet, Sethi and Prakash Padukone. Geet Sethi, as you know, is a 9-time world billiards champion. Prakash Padukone, I have to tell many youngsters that he's not just Deepika's father. He's played a little bit of badminton in his life, and they had started this not-for-profit organization called Olympic Gold Quest with a very sharp mission to help Indian athletes win Olympic gold medals. And they were looking for a CEO. Now, this was back in 2009. Now, Geet and Prakash were gods for me as well. I could not say no to them, and I just felt that OGQ gave me the platform to help the next generation of athletes do something that I couldn't do myself, which is help Indian athletes win Olympic gold medals. I'm going to tell you a few stories about OGQ and the journey of those champions. I'm going to tell you 2 stories about, you'll all know athletes like PV Sindhu, Mirabai Chanu, etc., who have won medals for India. Sindhu has won 2. But maybe what you all don't know so much is actually the blood, sweat, and tears that went in the lead up to in that journey to the Olympic podium. So I'm going to share a couple of stories with that. But before that, I'm going to request my friend Anand to kindly play a small video, just to give you context. OGQ looks after the training and preparation of some of India's best athletes preparing for the Olympics and Paralympics. The Commonwealth Games is an important stepping stone. We're very proud to say that at the recent Tokyo Olympics last year, India won 7 medals. The training of 4 of the 7 medal winners was looked after by OGQ. And thank you. At the Tokyo Paralympics, India won 19 medals. To give you context, the highest number before that was just 4. And the training of 10 of those 19 medal winners was looked after by OGQ. The video I'm about to show you is from the recent Commonwealth Games in Birmingham. It's an important stepping stone in the lead up to the Olympics. Commonwealth Games, Asian Games, World Cups, World Championships, these are all important stepping stones. 23 athletes supported by us participated at the Birmingham Commonwealth Games. 17 won medals, including 12 gold medals. You will see all the medal winners over here. If I can request Anand to kindly play the video, please.
Yeah, you can be the greatest, you can be the best, you can be the King Kong banging on your chest.
You can beat the world, you can beat the war, you can talk to God, go banging on his door.
You can throw your hands up, you can beat the clock, you can move a mountain, you can break rocks.
You can be a master, don't wait for luck, dedicate yourself and you gon' find yourself
standing in the Hall of Fame. Yeah. And the world's gonna know your name.
You can run the mile, you can walk straight through hell with a smile. You can be the hero, you can get the gold, breaking all the records they thought never could be broke.
Yeah, do it for your people, do it for your pride. Are you ever gonna know if you never even try?
Do it for your country, do it for your name, cause there's gonna be a day when you're
standing in the Hall of Fame. And the world's gonna know your name.
Politicians be preachers, yeah. Be believers, be leaders, be astronauts, be champions, be truth seekers. Be students, be teachers, be politicians, be preachers, yeah. Be believers, be leaders, be astronauts, be champions,
standing in the Hall of Fame.
Yeah.
And the world's gonna know your name.
I know you all are doctors, but you are allowed to clap louder also, okay? Okay. It takes just 6 grams of gold to lift the worth of a nation. 6 grams of gold, that's the weight of pure gold in an Olympic gold medal. And the journey to that podium and to that gold is actually hell. And in sport, what generally happens is we see the final effort, but actually, I want to talk to you a little bit about what goes behind the scenes over here. At the Tokyo Olympics, I thought I'd do a comparison with some of the big nations in the medal table. India has 1.3 billion population. I looked at China, I looked at the US, Great Britain, Germany, Australia, etc. But in terms of medals, they're far out of reach. So I thought I'd do a comparison with a nation that's closer to us in terms of medals. I looked at Hungary. I googled Hungary's population 10 million, which is basically the population of Dada railway station on Monday morning at 9 a.m. Okay, and India won 7 medals at Tokyo. Can anyone guess how many medals did Hungary win at Tokyo? Hungary, small dot on the map. We'll take 1 minute to find where Hungary is on the map. Hungary won 20 medals overall, including 6 gold medals. And when we actually analyze what is Hungary doesn't have more facilities than us. They don't have smarter doctors than us. They don't have more money than us. And yet Hungary is winning 20 medals at the Olympics, the ultimate stage of world sport where you're competing against the best in the world. And one of the things that nations like Hungary do really well is focus intensely on a few sports that they're really good at and go deep. And that's one of the lessons we learn to win Olympic medals. You have to just focus, focus, focus. Like I said, growing up, I remember I had so many injuries during my hockey is a contact sport. I had 4 fractures just on the fingers of my right hand during my playing career. Every time I had a fracture, I was out for approximately 3 months. So I lost 1 year just because of 4 fractures on my right hand, leaving aside the other injuries I had throughout my career. So, and I remember at that time, early 90s, late 2000s, we didn't have the best doctors. We didn't have the best support team, physios, trainers, nutritionists, mental trainers. I would be running from pillar to post. I don't know whether Dr. Narvekar is here. I used to see Dr. Narvekar for my knee at that time. And now things are much, much improved. And the easiest thing we can do is complain and grumble and say that India's shit, facilities are bad, coaches are useless. But I think what I loved about Geet and Prakash is they never complain. They wanted to do something to actually make a difference. I'm going to tell you about Sindhu's story. For me, one of easily the greatest athletes India has ever produced, male or female, at the Olympics. Everyone knows Sindhu today as one of India's best, but actually we started supporting her when she was 13 years old, a little girl in school. And I remember at that time, we were researching on this young girl who was beating kids 3 years elder to her. That almost never happens in a physical sport. We started supporting her immediately. I remember on day 1, I went to Hyderabad, Gachibowli. I met Gopi and her parents. And I asked them if there's one thing that OGQ could do for Sindhu, what would it be? And they unanimously said international exposure for training and competition, because Sindhu was not in the Indian team. Her parents did not have the funds to send her abroad for training, so she was not getting any international exposure. OGQ was a new not-for-profit organization, 2009. We didn't have any money, but what we had was a lot of belief in Sindhu's ability. We somehow put together the funds to send her for 5 international tournaments abroad with a coach and a physio. That was the time she won her first senior international tournament, a Chotusar tournament, Maldives International Challenge, but very big in terms of the confidence it gave a young girl. At the age of 17, Sindhu started playing Super Series tournaments, the highest level of women's international badminton tournaments. That first year, Sindhu played 12 tournaments. 10 tournaments she lost in the first round. And you can imagine the hit it took to the confidence of a young 17-year-old girl. And in India, you know how it is, right? At the age of 15 and 17, you make decisions in life. Should I study or should I play? Sindhu's elder sister, by the way, is a doctor. And when you're losing not once, not twice, not thrice, 10 times, there seems to be no light at the end of the tunnel. Sindhu almost quit badminton that year. I've seen her throw her racket on the floor in Gachibowli and said, I do not want to play badminton any longer. I'm not good enough. And I recognized it from my own experience that was the most crucial time in the life of an elite athlete, that transition period which is the hardest, where you want to give up 1,000,000 times to be able to hang in there and believe in the process. We gave her a very good psychologist. I think we ensured that there was a very strong team supporting Sindhu, and luckily the tide turned and she started getting better. Not many people know that exactly 9 months to the day of the Rio Olympics, one day Sindhu got a stress fracture on her foot. We showed her to all the best orthopedic surgeons, took all the scans. Everyone said very clearly that she's out for around 4 months. That was the injury protocol. Within 12 hours from the injury happening, Gopi, Sindhu, her parents, our team of our physio, trainer, nutrition, mental trainer, we sat together. We prepared a day-to-day plan of Sindhu's rehabilitation, her recovery, her strengthening, return to jogging, return to training on court, and finally return back to competition. In exactly 3 months, 10 days from the date of the injury, Sindhu played her first competitive match again. And I think that was world-class recovery and a world-class rehab program just because of teamwork and the dedication and commitment of an elite athlete who made it happen. And when Sindhu eventually went to Rio, she was in the best shape of her life. Not just physically, but I would say mentally. She beat 3 opponents who had better head-to-head records than her. All three were higher ranked than her. And I was there at Rio and I asked Sindhu, what happened? How come you played so well? And she told me something that meant a lot to me. She said, Viren, she was 21 when she won the Olympic silver medal at Rio. Did anyone watch that match? Did anyone watch Sindhu's match? At the a lot of hands going up. And we all felt proud, right? Seeing an Indian girl going there. And what Sindhu told me made me feel really proud because she said, Viren, in the last 7 to 8 years that OGQ has been supporting me, the support has been so world-class that every time I stepped on court in Rio, I just believed that I could beat anybody. And for me, that meant so much from a young Indian girl saying that, because I think that in 2004, when the Indian men's hockey team stepped onto the pitch in Athens against Australia, and we stood toe-to-toe and face-to-face with them, I don't think deep down at that point of time, we believed that we could beat Australia. And I think belief does not come from you or me telling athletes, have confidence, have belief. It actually comes from solid world-class support from all of you all, from everyone working in the team with athletes. If we are able to consistently give our athletes the best possible support, I don't see any way that we can't win at the highest level. So for me, Sindhu is just an incredible athlete. She went on to obviously win a second Olympic medal at Tokyo also, which was even tougher than the first, just given the circumstances that she could go through. That was me with Sindhu at the Rio Olympics. Mirabai Chanu, she came from a background so poor, growing up from a small village far away in Imphal in Manipur. Mira did not even have 2 square meals a day to eat. She used to lift firewood to earn 10 rupees for her family. Hardy, tough girl from the mountains, she became a weightlifter. Now her journey at the Olympics actually started with failure. Because at the Rio Olympics, Mirabai Chanu failed in all her 3 lifts. Mira is she's a 49 kg weightlifter. So her weight has to be less than 49 kgs. In her weight category at the Olympics, you have to clean and jerk about 115 kilos. So you lift the bar up to here, this is called clean, and then you jerk it up. Okay, 115 kilos, that's about 2.5 times her body weight. Again, to give you context, I am 80 plus kilos. I cannot lift that bar 2 centimeters off the ground. Because if I go to lift more than that, I'm going to get a back injury for the rest of my life. So and this is a 49 kg lady doing that. the OGQ team was tracking Meera in the lead up to Rio, and she was not expected to win a medal at Rio, but she was expected to challenge and go very close. So we were very surprised when she didn't make a single clean lift at Rio. And we were curious to find out the reason. So in December 2016, I made the journey to Patiala, which was Meera's training base, to find out what happened. I had dinner with Meerabai Chanu and her coach, Vijay Sharma. That dinner turned into a 4-hour meeting. And in that 4-hour meeting, Meera was actually sobbing on the table for more than 2 hours. As she was narrating what happened at Rio, she said that mentally, the pressure on her was so much that she just blanked out. And she forgot the process of, and weightlifting is a process. If you forget one element of the process, you will not make a successful lift. She equated it to someone preparing for a very public speech for 5 years, and then when you go on stage in front of 1 million people, you forget all your lines. From that talk with Meera, from that meeting with Meera, it became very clear that there were 3-4 major deficiencies in her training. Her coach was very young and talented. He understood modern training methods. But what she didn't have was the medical support and the absolutely world-class team working behind the scenes with her. We had to put in place a very good psychologist first and foremost, because we had to help her overcome that fear of failure that kept plaguing her every time she went onto the platform to lift in competition after Rio. Second, we had to get a very good nutritionist, because we had to keep her weight below 49 kgs, yet have the explosive strength to lift 115 kilos. We had to get a very good strength and conditioning expert to work with the coach on technique, because when you're lifting weights that normal people cannot even think of, any mistake in technique and the probability of injury multiplies a lot. And last, we had to get a very good physiotherapist with her, because I'm a hockey player, I've seen a lot of injuries. We look after boxers, wrestlers, but I've never seen the kind of injuries that weightlifters get. In the last 3 months in the lead up to the Tokyo Olympics, Meera on separate occasions had 4 injuries. She had a back injury, she had a neck injury, she had a shoulder injury, and she had a thigh injury. And each time we thought, oh God, that's it, 5 years of effort again gone down the drain. But that lady is made of something else. Every time she kept fighting, pushing the pain barrier. And finally, 24th July 2021, first day of competition of the Tokyo Olympics, Meerabai Chanu finally lifted 115 kilos and won the Olympic silver medal. And all of us cried buckets of tears. I cried because I know how hard the journey was for me, for her. And after the Olympics, Meera told me that she did not sleep properly for a month in the lead up to Tokyo as well. Just the burden of expectation on her was so much. And for me, she is definitely one of the most incredible athletes. I just want to add another nugget. Exactly 3 months after the Tokyo Olympics, they had the weightlifting national championship. The number of girls that participated has tripled from the last national championship, just because of a hero like Meerabai Chanu. In the Northeast, every academy is filled with young girls who now believe that they will be the next Meerabai Chanu. You can see how tiny Meerabai Chanu is, and this girl is just an incredible young talent. I just want to end by saying I think the greatest pleasure in life is to do something that people say you cannot do. I think especially in sport, I've always heard right from the time I was growing up, people say, don't play, you'll never get anything, India's useless, we're too bad. Now in OGQ, people say, you all will never win Olympic medals, we are too far behind the rest of the world. I just want to say a personal story. When I was 12 years old, I was a really tiny kid, very puny, very short, very thin. This is 12-year-old me, and you can see the other 12-year-old, who I was much smaller and tinier compared to. And I used to go to the AstroTurf Hockey Stadium in Churchgate for training, for these summer coaching camps. And I thought I was a very talented hockey player until one day one very senior coach caught me by the scruff of the neck and he said, ki, Viren, you're very skillful, you're very talented, blah, 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 but you'll never ever play big hockey in your life. And I was very upset that this very senior coach is saying that I'll never play big hockey in my life. And I asked him, sir, why do you say that? So he just said, ki, you're just not strong enough, you're not fit enough, you have zero endurance. I had a asthmatic issue, my breathing, my lung power was really bad. I went home very upset. From the next day onwards, every single day I came onto the hockey pitch, I started working on my skills. I either learned a new skill every day or I improved on my existing skills. I started going to the gym, I started getting fitter, faster, stronger. And exactly 12 years later, at the age of 24, I captained the Indian hockey team for the first time ever. And I was very glad that that coach one day told me that you will never ever play big hockey in my life. Because maybe that day, if he had to not tell me that, maybe I wouldn't have worked as hard as I was supposed to work to get where I was supposed to be. And so I just want to say that I think, when Geet, Prakash, Vishwanathan, Anand is also on our board, myself, and we started OGQ, we thought that the potential and possibilities of this are good. First we thought we just make it a fine program where former athletes help the next generation of athletes do something. But actually what we really want to do is make it a movement that can capture the imagination of the entire nation, right? All of you all felt proud when you all saw the video. And that's what we want to make millions of Indians feel really proud. And I want to say a special thank you to Dr. Joshi, Dr. Dinshaw Pardiwala, Dr. Abhay Nene, Dr. Narvekar, Dr. Sanjay Desai, Dr. Sudhir Warrior, many doctors who have helped many of our athletes and many others. I'm sorry if I have not taken your names, Dr. Aditya Daftari. So many of you all at next to no time always see our top athletes. And without that support, these are the 1%ers that will get us back. Because in the life of an elite athlete, the window is very short and that window closes very soon. In the previous session, Dr. Agarwala was saying about recovery time, and it's so important that's magnified in the life of an Olympic athlete because we have to get them back into action at the quickest time possible. Every time I was out with my finger fractures, I lost my place in the Indian team. I lost my confidence. My fitness level dropped to 0. And I had to fight my way back into the team from scratch. So getting elite athletes back into action is quickest, and very often it's not just the physical aspect of the injury, it's the psychological aspect which is the hardest for them to deal with. So what we want to do is make OGQ a movement that can capture the imagination of the entire nation. I think as with anything in life, the choice is always ours, because when we walk out of those doors today, I think many people in life will tell us that you can't do this and you can't do that. If there's just one message I like to give, especially young kids, is that if we put our minds and our hearts and our soul and put the best team in the world possible, I think we can do whatever we want in life. Yeah? Thank you very much. Thank you. Thank you. Thank you, doctor. Thank you. Thank you. Thank you, doctor. Thank you. Thank you, doctor. Thank you. Very well. Thank you. Thank you, doctor.
Thank you, Viren. Thank you, Dr. Anand Joshi. That fantastic inspirational talk leads us up to our next speaker, who's indeed a youth icon. Dinshaw Pardiwala recognizes himself as the head of sports medicine in Kokilaben Ambani Hospital. But to us, he's our representative at the ICC, at the BCCI, at everything that's sporty. He's truly redefined orthopedics. Dinshaw Pardiwala for the BOS has been a multiple times Masala Wala Paper Award winner and a Young Surgeons Forum winner. But for me, he embodies the phrase, the meticulous Bawaji. My dear friend Dinshaw, the stage is yours.
Thank you. But before I get on to my lecture, I'd like to say Viren, who's a very close friend, didn't win an Olympic medal for himself, but through OGQ, he's won multiple Olympic medals for India. So thank you, Viren. And Viren spoke about building champions, but as sports orthopedic surgeons, it's for us to ensure that our champions remain champions. And before I start, I'd like to just say a quick thank you to the patients and the athletes who've consented for their names to be included into this presentation. And one more disclaimer. I know as orthopedic surgeons, we love scientific details, but you'll forgive me if for medical confidentiality issues, I can't get into the nitty-gritty and the details and the orthopedic details that we'd like for each of these cases. In the Rio 2016 Olympics, Vinesh Fogart, who was one of our medal prospects, sustained a very severe injury to her right knee. She dislocated it. She had to be stretchered off. She went to the local Olympic hospital there and had to be reduced. She then had to be flown back to India, where we had to do a surgery on her, a multiple ligament reconstruction. She was very keen to receive her Arjuna Award in person from the president, so we had to put her into a cast, which we normally don't do. So she got into a cast. 4 days later, flew to Delhi, got her award, came back, stuck with her rehab. 7 months later, returned to wrestling, won a silver medal at the Asian Wrestling Championships. And then 2 years later, the Gold Coast Commonwealth Games in 2018, she won her gold medal. The same year in the Asian Games, she won a gold medal. And this was all done without too much ado, without too much shusha. So what are the strategies that we as orthopedic sports surgeons employ to ensure a quick and safe return to sports following injury in elite athletes? Because injuries will take place, but if we can't get our athletes back on court, on the field, on the mat really quickly, they're going to lose that competitive edge very quickly. And I think that there are 7 strategies that we employ, and I'll go through each of these. The first is advanced diagnostic medical imaging. Unlike our normal patients where, of course, you do a clinical evaluation and then based on that, maybe try a trial of non-operative treatment, and then if that doesn't work, get an MRI done, and then take it based on the merits of the case. In our elite athletes, we like to reach that diagnosis immediately, and that sometimes does mean over-investigating them, but it's best to get that diagnosis quickly. And I'll give you 2 examples. This fast bowler, left arm fast bowler, who presented to me with a vague pain in the shoulder and who had some minor neurological symptoms after bowling 10 overs and not before that. When I clinically examined him, he had almost no signs at all. But we knew that there was something wrong, that MRI was normal, and so we persisted with that diagnosis, and then it's only when we get an advanced study like a CT angio done, looking out for a rare sort of vascular cause, that we found that in that hyperabducted position, he had a pseudoaneurysm of the axillary artery, which was then causing his distal symptoms and which required a surgical excision. So sometimes we really need to push with our investigations. One more case, a badminton player with anterior knee pain. And if you look at the MRI, that MRI looks not that bad. This is not a significant chondral injury. But it's only when we get the DGEMRIC, the delayed gadolinium enhanced MRI done, that we notice that it is quite a significant injury to that articular cartilage. And when we get the T2 mapping done, we see that this is a large zone of degeneration, and on that she's got a small little chondral crack there. So this completely changes the treatment and the prognosis of return to play in an athlete. So I think the first point is making sure that you've got a quick diagnosis with the sort of investigations that you need. The second is decision making. And it's always the decision between surgical versus non-surgical. And this is a critical decision because you don't get a second chance. Unlike our normal patients where you'd give them a trial of non-operative treatment, and if that doesn't work, maybe 2 months down the line, we'll think of employing a surgical cure. In these patients, because time is short, you need to take that call early. Is my non-operative treatment certainly going to get this player back? Because if it's not, then I better employ a surgical treatment that's going to get him back faster. Take, for example, shoulder dislocations. So if you land up with an anterior shoulder dislocation, something that this player had, a classical hyperabduction injury. So he's fallen, his arm's gone into abduction with external rotation, and he's landed up with his first time anterior dislocation, which of course was reduced there by the sideline. Now, a player like this, because he's a right arm fast bowler, is going to require a surgical treatment, which otherwise we would have done a non-operative treatment for. So if it's the non-dominant arm, or if it's not a contact athlete, we may opt for a non-surgical treatment. But if it's a player for whom this is the dominant arm, it's probably best to go ahead and stabilize this early itself. And so the whole concept of primary repair for first-time anterior shoulder dislocators. And what do we do in that? Arthroscopically go down and get your anatomical repair. So you've got the torn anterior labrum there. We put in anchors, take bites through the suture, take bites through the labrum and the anterior glenohumeral ligament, and get back an anatomical repair. So if we've got a nice taut anterior glenohumeral ligament here, and we've got our concavity compression effect restored, then his static stabilizers will do their job, and his dynamic stabilizers can then be used for strength and for generation of pace, and don't really need to be working as the secondary stabilization mechanism. So sometimes for our athletes, we'll choose surgical treatment over non-operative, unlike our normal patients. Similarly, in muscle tendon tears, this fast bowler with a left-sided quadriceps, this is a central rectus tear. This is something that we might treat non-operatively in normal patients, but in our elite athletes, if someone needs to sprint, this footballer is going to get a primary repair, which is then going to enable to get back to sports earlier and prevent recurrences in the future. I remember in our residency days, we used to do adductor tenotomies under local anesthesia percutaneously, and most of our patients used to adapt well to those. But if a sportsman lands up with an adductor longus tear like this one here, and this is an avulsion straight off the bone, this is again something that we'd like to go ahead and repair primarily. So put in suture anchors, repair that adductor longus, and typically these are associated with an extension which goes into the core muscles and the rectus. This too would need to be repaired. So again, a little more aggressive approach in elite athletes as versus normal recreational athletes. And also for ankle sprains. Typically, we treat ankle sprains non-operatively in most of our patients, but in an elite athlete like this badminton player who's landed up with ATFL and a calcaneofibular ligament CFL tear, this is something that we will do a primary repair for, because this gives that player the best opportunity for restoring anatomy and therefore being able to restore and getting back to sports. The next strategy is arthroscopic surgery whenever possible. So we know that minimally invasive procedures enable our athletes to return back to sports faster than open procedures and should be used as and when possible. So take, for example, this injury. This is a goalkeeper who's got a direct impact on his proximal tibia. And you'll see that direct impacts landed up with a PCL injury. Now, if you had to do a PCL reconstruction open, that's a significantly morbid procedure that's not going to get him back for at least a year. Whereas doing an arthroscopic single or a double bundle reconstruction will enable him to get back to sports in about 6 to 7 months. So as and when possible, an arthroscopic procedure. And we've seen this in multiple joints, whether it's the shoulder, the elbow, the wrist, the hip, the ankle, the knee, and other areas of the foot. It's an arthroscopic approach that will often give you a faster recovery and therefore faster return to sports. The next strategy that we use and which has really helped change the way we treat our patients is technological advances in the medical devices that are available. And industries ensure that we've got devices and implants that are stronger, smaller, and enable a better surgical repair. So take, for example, this young parkour specialist, and he's from Bombay itself. Parkour is a sport that's catching and becoming more popular over the years. And this is a sport that requires a lot of agility, it requires strength, and it requires you to have mobility. Now, when he lands up with an ACL tear, with an MCL tear, and a locked, transected buckle handle tear of the lateral meniscus like this, what's called a terrible triad of the knee, if you don't repair the meniscus, this patient is probably not going to get back to normalcy. Now, to repair a transected meniscus is not an easy job. You don't have much space. So this locked meniscus first needs to be reduced. And you'll see that this is a complex tear. It's torn not just radially, but also in the periphery. Now, to repair this, you need devices that are going to be all inside and which are going to fix this meniscus to the periphery first. So this is an all-inside device that achieves that. And then once you've done that, you need instrumentation that's so small that can get into that small lateral compartment, and that 1 or 2 millimeter needle can pass a suture through, and you can suture that entire meniscus back into anatomic congruity. So something that you do with a complex fracture of putting all those pieces in position, you do that with the meniscus. And for many years, we believed that the menisci did not heal. But you'll see when we do this second look arthroscopy, when we go down for his ACL reconstruction, because we've done his MCL repair and his lateral meniscus repair in the first stage, when we go down in the second stage to do his MCL reconstruction, you'll note that that's the lateral meniscus, that complex tear of the lateral meniscus that's healed out there. And it's only because the lateral meniscus is healed that we can then allow him to get back to his high demand activities. Because without that lateral meniscus, there's no way he's going to be able to get back to his training and get back to the sort of stuff that he wants. So when you've done an ACL reconstruction, a primary repair of the MCL, and you've repaired that lateral meniscus, you've gotten back anatomical congruity, and then that enables this high demand elite athlete to do the sort of stuff that he'd like to do. We do know that repairing and biomechanically bringing back structures to their original anatomy is useful, but sometimes, unless you get healing, you're not going to have normalcy. And that's where orthobiologics and regenerative medicine comes in. And take, for example, this case of a fast bowler with a locked lateral meniscus bucket handle tear. So he's got that flap of the lateral meniscus that's torn off and then locked within the horizontal cleavage tear of the lateral meniscus. Now you'll note that this meniscus tear is in the region of the popliteal zone. Now the popliteal zone has no peripheral attachment and therefore has very poor vascularity, and we know that traditionally these tears will not heal. Not only will they not heal, but they will progress with time. And this small little injury is likely to be a career-ending injury for this fast bowler. Now, knowing that, we know that we do need to repair these tears. And we can use these very nice, elegant devices to repair them and stitch them up. But if we don't get healing of the two leaves of the horizontal cleavage tear, this repair is not going to function. And that's where orthobiologics come in. So what we then use is an exogenous fibrin clot. So we take some of the patient's own blood, prepare an exogenous fibrin clot, insert that clot in between the two leaves of the meniscus. And there are a few studies now which have been published since many years which show us that these exogenous fibrin clots enhance healing. They help with the biology. They help as a chemotactic factor to enable the healing process. And once you've got that sandwiched in there between the meniscus, you'd go ahead and repair it and stitch it up. And you'll note that that's the repair, and 6 months later, your MRI shows that it's a healed repair, and this young boy went back to bowling 7 months following his surgery. Now, Orthobiologics are used in multiple other sites, and we've got an entire symposium on them coming up tomorrow. Though I would warn you that this is still an evolving science, and not everything that's proposed to achieve what it says it will. So when you're using an orthobiologic, it's worthwhile to be sure that what you're using is going to be useful. The next, and I think that this is really critical, and Viren alluded to this in his presentation too, is advances in sports rehab and technology and sports biomechanics. When Neeraj Chopra tweeted this photograph after winning the Olympic gold in 2001, everyone, I think, appreciated his effort, but I think people didn't really realize the effort that went into the rehabilitation process following his elbow arthroscopic surgery. So you can do an elbow arthroscopic reconstruction, but if you can't get that elbow to get back full range, full strength and stability, and thereafter get back explosive strength, ensure that you can generate the biomechanics from the core to the shoulder and get back your throwing mechanisms, there's no way that you'll achieve what you ultimately want to achieve. And I really like the OGQ motto. It takes 6 grams to lift the worth of a nation. And you can see that this one particular throw lifted the worth of over 1 billion people. And that's possible because of the extensive rehab that he's done and the extensive biomechanics corrections that have gone into ensuring that he can throw stronger and better. And finally, a better understanding of sports biomechanics. This is something that we just didn't give attention to initially. We can restore anatomy, we can get back range and function, but if we can't get back biomechanics, then that sportsman is probably going to be ineffective. And I think the best case example for this is this fast bowler that we operated in 2014. He had an ACL tear and a lateral meniscus root tear. And of course, he underwent an ACL reconstruction with a lateral meniscus root repair. But what we had to analyze was his biomechanics, because he had not only a very awkward bowling action, but he required 20 degrees of hyperextension. And we know that hyperextension in the left, because he's a right arm fast bowler, the knee extension angle at ball release dictates how fast you're going to be able to bowl and how accurately you're going to be able to bowl. So to get back that 20 degrees of hyperextension in the left side post-surgery and to ensure that it's stable at that range is important for this fast bowler to get back to 100%. And I think that that understanding of sports biomechanics then enabled him to get back to the best that he could be. So these are the 7 strategies that we employ as sports orthopedic surgeons to ensure that our athletes can get back as quick and as safely as possible. Now, how successful actually are we in this process? So we analyzed the elite athletes, and by elite we define them as either players in cricket who represented India at any stage, or for non-cricket as players who represented India at any stage in their career. So when they had an injury and they underwent surgery, how many of these could we return to sport? That's RTS. But more importantly, how many of these could we return to performance? RTP. And we analyzed these cases that we've done from 2015 to 2021. And yes, return to sport may be very encouraging. 96% returned back to sport. But only 9 out of 10 could get back to their original level of performance as they had prior to the injury, which means that we still have to help that 1 out of 10 player, and that's where we need to really ensure we get in the coming years. So what are the things that defeat us? So injuries which are very severe, combat injuries in which there's a bony element, like this girl who had a prior ACL reconstruction, but then had a fracture dislocation of the knee with significant articular cartilage and meniscus loss. I think these are the sort of injuries where bones involved, multiple ligaments involved, meniscus losses involved, articular cartilage losses involved. I think these are the ones that still defeat us. The second ones that defeat us is our slightly older athletes with degeneration, We're seeing degenerative joint disease at a much younger age, like this 27-year-old male wrestler. You can see what his shoulder looks like, almost like a 70-year-old's. Or this 31-year-old male football player. His cartilage is completely lost on his medial femoral condyle. So degenerative joint disease is still a big, big challenge for us. And hopefully in the years ahead, we'll be able to get our slightly older athletes also back to sports with improvements in orthobiologics and maybe other technologies that come in. Viren mentioned that it's important to build champions. But if India's destiny as a sporting superpower really is to be achieved, I think our medical science, our sports science, and our sports orthopedic support really can't be lacking. And I think that we've really improved over the last 15 years. We're standing on the shoulders of giants, but I think that we still have a long way to go. Thank you.
Ladies and gentlemen, Dinshaw Pardiwala, thank you for making us so proud and thank you for keeping our athletes on track, Dinshaw. The strength of an ox, the eyes of a hawk, and the heart of a tiger. That's what defines an orthopedic surgeon, isn't it? So, in keeping with that theme, the last presidential lecture takes us to the wild side. To introduce the Dean of the Wildlife College of India, we have, again, someone in the same theme, someone with the strength of an ox, the heart of a lion, and the eyes of a hawk, our past secretary, Dr. Rujuta Mehta.
Sure. Please. Ladies and gentlemen, I will not stand too much between your presidential guest speaker and you, but I think it's a proud privilege to belong to the same school as Mr. Yadvendradev Jhala. Some of us have been hearing about real-life heroes and human work. And there are some heroes in the background who do inhuman work because it is literally not with humans and not possible for a lesser mortal like us. And they make such a lot of difference, not just to the country, they do the country proud, but also they make a huge difference for generations to come. For those of you who are not familiar with Mr. Jhala, Dr. Jhala has led a long-term research project on the Asiatic lions. Mr. Jhala has been working on the Project Tiger, where he designed and implemented on national scale for the population assessment of tigers and other carnivores. And his wildlife survey has been put in the Guinness World Record. Ladies and gentlemen, I give you Mr. Yadvendradev Jhala, the man who brought the cheetah to India after extinction.
Thank you. Thank you very much, Dr. Mehta, Dr. Gandhi for inviting me, Wiroc for organizers for giving me this pedestal, my school teacher, Ketkiben, my friend, Dr. Ravi Gupta, esteemed gathering of orthopedic doctors, Namaskar. I work for the government, the Ministry of Environment, Forests and Climate Change. We are actually the technical arm of the ministry, Wildlife Institute of India. Primary role is to train forest officers in managing national parks and wildlife sanctuaries. We also do research, and I'm an academician. The criteria of judging academicians is how many scientific papers you produce, how many grants you raise, but when your research actually gets translated into conservation actions, it is like Sone Mein Suhaga. And I'm going to tell you how science has been used in wildlife conservation in India and how research has actually guided policy and management in our country. Scientists don't even know how many species exist on this planet. The estimate is anywhere between 10 to 30 million, but it's a guesstimate. We don't know that. Just like birth and death, evolution and extinction are the two sides of the same coin. Any species which evolves is bound to become extinct. Today, after the loss of the dinosaurs 65 million years ago, we have again in the Anthropocene reached an extinction crisis. The background levels of extinction have been increased 100 to 300-fold. And this is because there is a single species that evolved on this planet about 2 million years ago, us. Luckily for us, we humans were also endowed with the intellect by nature to redress the negative actions of ours on this planet. We can do that if some of us realize it and act towards solving this problem. In India, the first humans appeared about 1 million years ago. It is only within the last 40,000 years when humans learned to use fire did we change the habitat to make it more conducive for ourselves and less conducive for our conspecifics, the biodiversity of this planet, which started declining because of us. But it is in the last 2,000 years when we established civilizations that our impact has escalated to a global extinction crisis. And some of our jobs, like the one I do, is to prevent this extinction which is caused by anthropogenic means. India shares a huge amount of biodiversity compared to its geographical area and the population pressures that we face. We still have a lot of animals and plants, microbes, organisms which you deal with on our area of the planet compared to the other parts of the world. And this has survived on our planet primarily because of the religious and cultural attitudes of our people towards nature. In the Western world, usually the Western religions, the Abrahamic religions, with no offense to any religion, talk about humans as being dominion of nature. We conquer nature for its use. The Eastern religions of Hinduism, Buddhism, and Jainism talk about custodianship of nature. And this basic difference has allowed nature to persist on our part of the world compared to the other parts of the world. It's not because of the forest department or scientists or managers who've done this, but it is the people of India who have conserved nature for millennia. However, our attitudes and values are fast changing. The population pressures on this planet are fast changing, and that creates a crisis for our area. When we have 1.3 billion people living in India, the pressures are humongous. The GDP which we maintain, the development which we do, is all impinging on the human footprint which are creating in our part of the world. It was not only the ethics of conservation, but when the world was a barbaric part in the western side, we actually indoctrinated the principles into policy and law. And the first policy on nature conservation can be seen in the Arthashastra of Chanakya. The Yellowstone National Park is considered to be the first national park in the world, 1857 or something like that. But during the time of Ashoka, we had Abhayaranyas in our country about 400 BC. So India has been a leader in conservation, and we take this leadership in the modern era as well. When I started work with tigers, that was in 2002, I had been working with lions and other carnivores initially. But in 2002, I was asked by the ministry to help them assess tiger populations across the country. And that point in time, we were going through a crisis in tiger conservation. We had lost two tigers in two tiger reserves, Sariska and Panna. The Prime Minister had formed a tiger task force. And one of the major limiting factors in tiger conservation was false numbers of our populations. Now, counting wildlife is like counting crows in Delhi. And if you remember the famous episode where Akbar asks Birbal that how many crows are there in Delhi, Birbal very wittily answered that it's like close to be about 10 lakh crows in Delhi. So Akbar was surprised. He asked, how is it possible that you know this? He says, sir, just count them. He says, you know it's impossible to count crows. He says, you count them and you'll find them to be about 10 lakhs. What if there are more? He says, oh, the neighboring villages, the crows are visiting their relatives in Delhi, and that's why the number is more. What if the number is less? The crows from Delhi are visiting their relatives outside. So it is it's a no-win situation. You can say anything you like. And at that point in time, we had a population estimate of about 3,500 tigers in India, official record. When we did this with a scientific method, we found that there were only around 1,400 tigers left in our country. And this shook the entire policy of the government of India, and the subsequent research which came through with our work was actually changed the Wildlife Protection Act. It was enacted in the parliament, and the act was amended, and a lot of reforms took place. Now the question is, how do we do this? Just like you have fingerprinting for humans, we fingerprint tigers based on their stripe patterns. Each tiger has a unique stripe pattern. So if they take selfies of themselves when they walk on forest trails with remote cameras, you can use this information in counting tigers. But there are problems associated with that. Tiger doesn't, give a very nice selfie. It, may give you a side profile, front profile, and you don't always get the fingerprint right. So you have to have computer models which correct for pitch and roll, and artificial intelligence which allows you to compare one tiger from another, because it's humanly impossible to do that. We also use this information to fight tiger crime. For example, this skin which was seized in, I don't know if this shows up here, no it doesn't, but if you can see the skin here which was seized in Kathmandu, it was traced, you could trace it to a tiger in Pench Tiger Reserve in Madhya Pradesh, where the live tiger was photo captured. So maintain a repository at the Wildlife Institute of India, and you can get to the hotspots of poaching and address those, because you know where the tiger crime is coming from. So as Dr. Mehta mentioned, this survey, the last survey which was done, not by me, but I'm the lead scientist on that. It was done by the Forest Department of all the tiger states, along with the National Tiger Conservation Authority. We got the Guinness Book of World Records for the largest wildlife survey conducted on this planet. And you can see the effort which is put in. About 44,000 people working across the country, about 5 lakh kilometers of walk. We covered an area of about 33.8 lakh square kilometers, and we found that tigers occupied about 88,000 square kilometers. So each blue dot which you see on this map of India is a trail which is walked by a forest guard, and whenever he sees a tiger sign, either it's a pug mark of a tiger or a fecal matter of a tiger, it's marked in red. So you can get a distribution map of the tiger itself. And then we go in and put camera traps, and we take photographs of all wildlife. So the tiger census actually helps in assessing the entire biodiversity of a forested area in the country. Now I'll just give you a small brief, because it's a scientific talk. Oh, thanks a lot. But I don't need this, so thank you. This is much better off. So I'll just explain to you how this technique works. And this is a map of India, which shows you where the tigers are, their population extent. I'll just concentrate on this part of the Tarai, the foothills of the Himalayas, where the tiger population is. And if you see this green squiggles each represents a walk by the forest guard. It's about 5-kilometer walk, and it covers the entire area in which tigers are found in the Tarai landscape. So this is Uttarakhand, this is Corbett Tiger Reserve, this is Pilibhit and Dudhwa over here, this is Bihar, Valmiki. So you can see the extent right from Uttarakhand all the way to Bihar. And this area is Nepal. So just to orient you, after that, once you know this, we find out where the tiger signs are. So these red dots tell you where the tiger signs are. Subsequently, we put camera traps. So about 3,500 cameras, remote cameras are deployed in this area, and we photograph tigers. Okay? So we photographed about 598 tigers based on their unique stripe patterns. But mind you, not all tigers like to be photographed. They may not come in front of the camera. So there is an issue of detection. Okay? So need to be addressed through statistical models. And also you can't deploy cameras across where the tigers are found, because cameras are expensive, they get stolen, and so on and so forth. So that all needs to be accounted for. And after accounting for detection probability, that is tigers not appearing in front of the camera, we develop statistical models which allow you to predict the tiger numbers in an area with a reasonable level of certainty based on statistical confidence limits. So the model here, we look at tiger sign. Wherever tiger sign increases, that means more encounters of pug marks or scats, that is fecal matter. The tiger density increases. Wherever there's more human disturbance, tigers decline. And wherever there's more food in the form of prey, again tiger populations increase. So this gives you a tiger estimate of this area. Now this was actually telecast on National Geographic, made a nice film. I hope this voice comes. I'll just stop this for a sec. You need to attach that. Sorry about that. when we use technology, it has its own glitches, but I think this should work. Yeah.
80% of the world's
It's just a teaser.
After a loss in tiger population over the years, India, home to 70% of the world's tiger population, is turning the needle on the global tiger population.
Every 4 years, the Indian government undertakes a count to check the health of the population of tigers.
National Geographic brings you the story of India's national animal and the community of passionate officers involved in the biggest ever tiger head count.
Tigers need protection. So if you have good protection regime and you have good food, tigers bounce back.
Celebrate the moment of hope, pride and perseverance. Counting Tigers. Premieres 7th August, Wednesday, 8 p.m. on National Geographic and Hotstar.
So this gave us a lot of global coverage. It was screened in 9 countries, and it was wonderful. So see the efforts of the Indian government being portrayed across the world. Now this here is something which is familiar, maybe familiar to you. This is using microsatellites, genetic markers. Each bar represents a tiger here. So there are about 156 tigers from across India, and we're looking at the population structure of tigers to tell us if there are any unique genetic populations which need special attention for conservation and are actually declining. So what you see is the northeastern tigers, which is in Arunachal Pradesh, Assam, and those areas are very different from the rest of the tigers. The central Indian tigers are extremely diverse genetically because it's an amalgamation of South Indian tigers, which are also genetically unique and different, and this is an amalgamation zone having the maximum diversity. So we actually advise the government that the priority should be given to this area where there is a very little representation. The tiger population is actually depressed, as well as in the southern Western Ghats where the population are decreased. And this has been translated into the standard operating procedure by the government of India of where tigers should be artificially moved, when you need to move them, mix them, and so on and so forth. The same work has been done with leopards. Dhole is the Indian wild dog, and you can see the genetic structure. The leopard, for example, doesn't have a structure at all. And it is all mixed population. And that's because the leopard can move across human habitations as well, unlike the tiger, which needs forested corridors to move from one area to the other. The dhole also, the population is extremely mixed, except for this population, which is from the Tarai area, northern area. And that, I believe, is because there are wild dogs present in the Trans-Himalayas, and it is gene flow from that direction as well. For snow leopard, found in the higher reaches of Ladakh and Sikkim and Himachal Pradesh, we use a different technique because, of course, the spots on the leopard are also unique to them. But because of the long fur and the wind, you can misidentify them. The spots change from one photograph to another. So we developed a new technique of photographing their forehead and developing a model based on the markings on the forehead where the fur is short and the movement of the spots is not so much. But how do you get a leopard to actually give a selfie on its forehead? So we use an ingenious device, Calvin Klein perfume. The leopards just get inquisitive with this perfume and they go to investigate. So if you were to spray a little bit on the ground and then put a camera, you get a nice portrait of the snow leopard facing that and looking at it. And then we put transmitters on many of them, satellite collars, which give you information of where their movements are and so on and so forth. And we use this to estimate their population, their habitat use, and so on and so forth across the entire state of Ladakh. So again, this is the same thing what we do with tigers, and I will not beleaguer this due to lack of time, but this is using sign surveys, occupancy surveys, subsequently with camera traps, and you can come up with an estimate of snow leopards across the Himalayan states, which is far more difficult. Looking at lions, this used to be the historical distribution of lions, and of course, as you know, lions are only found now in the state of Gujarat, in Saurashtra landscape, and the protected area of lions is this Gir protected area, which consists of a national park and sanctuary. But in the last 15 years, lions have dispersed out of this protected area into a human-dominated landscape of about 30,000 square kilometers, where they share space with people. So you can have lions living in your backyards, and the people of Saurashtra have learned to live with these animals, which are quite dangerous actually. So how do we count the lions? Lions don't have body markings. Yeah? So you can't take a photograph and identify one lion from another. So we devised an ingenious way of looking at their whiskers. Lions have spots on their whiskers, and these are unique to every lion. The probability of mixing up two lions is about 1 in 10,000. So we use this information in a software and then estimate their populations using models known as specially explicit mark recapture. The crux of the story is, due to the human pressures in our country, the size of our protected areas are too small. Lions, for example, these are home ranges of lions. You can see they are much larger than the Gir protected area. There are about 1,700 lions living in 13,000 square kilometers, not all of them within the legal realm of protected areas. Tigers, if you see, we have the world's largest tiger population. About 65% of the global tiger population is in India, and the largest populations of tigers in the world exist in these three landscapes. But most of them live outside of protected areas. The possibility of, you can't fence our areas. Just like Kruger National Park, if some of you have gone on a safari to South Africa, you'll realize that 20,000 square kilometers of Kruger is fenced with an electric fence. So they have a direct zonation where people and wildlife don't mix. They don't tolerate conflict at all. In our country, people live with wildlife, and that's the difference. And there are conflicts, and these conflicts need to be mitigated urgently. We cannot afford to fence our protected areas because they are just too small. We also need to estimate how many of these large carnivores can actually fit into our reserves. And for that, you need to estimate something known as carrying capacity. How many animals, tigers, lions can be fitted into, say, a national park. And this is directly based on a relationship between the density of prey and the density of tigers. You can see it's a pretty good fit. And this allows us to estimate how many animals can be fitted in. I'll just skip this. The second thing which we do is do something known as an insurance policy, but not for individuals, but for populations. It's a risk assessment of how long a population can persist in an area. It is known as a population viability analysis. And what we see here are two different models. One is where a protected area, or national park, let's say, for example, Tadoba, which is close to you in Mumbai. Tadoba has only 15 breeding tigers. And Melghat, for example, has 20 breeding tigers. The chances of extinction in the next 50 years is very high in Tadoba, just because of sheer size of the population. This is estimated by knowing at the birth rate, the juvenile mortality, just like you do in insurance. Interbirth intervals, fecundity, survivorship of adults, and these are the population demographic parameters which are required, but you can actually predict the life of a population based on this. So this population viability analysis subsequently gets translated into the size and design of your nature reserves. For example, to sustain 20 breeding units, you need anywhere between 75 to 100 tigers in the core area of a tiger reserve, and together the population is about 100 tigers, and that is viable for the long term. So this is part of the management planning for tiger reserves at the landscape scale. But how do you create space in a human population of 1.3 billion people for biodiversity? Because tigers act as an umbrella. They are at the apex of the food chain. So if you conserve the tiger, you're conserving the entire biota. It's not a single species conservation program, but more of a biodiversity conservation program. Because if you have the top part of your ecosystem functioning well, the rest of the ecosystem functions are going to be doing well as well. So our strategy is to create space in the core area by moving people out. Unfortunately, the legal system in India, we don't have right to property. It's not a fundamental right of Indians. You can evict people for creating a dam, industry, widening of roads, but you cannot evict people for conservation. Okay? That's the Forest Dwellers Act, or it's called the Forest Rights Act of 2006. But you can't stop people from moving out if they want to move out voluntarily. So the Wildlife Protection Act gives an incentive of 15 lakh rupees per adult in the family to voluntarily move out of the core areas of a reserve. And this is the major strategy by the government of India to create space for wildlife. It is great for people as well, because if you're living in the forest, you're conflicting with wildlife, they're eating your crops, they can kill your kids, there's no education, there are no schools, there are no hospitals, no electricity, no marketplace to sell your products. But if you live outside, mainstreaming of society, then all this is available to you, and it's a win-win situation. It's a great vote bank because the people are very happy. They're going to give you votes, so the politicians love it, the people love it, and biodiversity loves it. So this is a strategy which is used by the government of India, which is not present anywhere in the world. So this is something which we need to be very proud of. So we are creating space for carnivores, for biodiversity as such. So what we want to do is have a landscape like this. This is a satellite view of central India. This is Kanha Tiger Reserve in Madhya Pradesh, Achanakmar in Chhattisgarh, Pench again in Madhya Pradesh, Satpura land over here. And you can see this is the forested area. So if tigers can move across these forests from one tiger reserve to another, perfect. This is what you want to do where populations are linked. There is gene flow between these reserves. However, if you put just roadways on it, infrastructure, these forests are fragmented. And this, you have to move, tigers have to move across these barriers. So what we do is we model the optimal pathways which animals are likely to take using modern theory of circuitscape. It's just like current flow between the least pathway of resistance. And as you see, these yellow areas are the paths of movement between these tiger reserves. These pink areas are cities, which are barriers. This is the city of Nagpur, the city of Jabalpur, and the highway number 7 passing and cutting this corridor between Kanha and Pench, forming a barrier to tiger movement. We see that genetics as well shows that actually tigers are moving across these landscapes, despite these barriers. But for how long? Especially when these roads become freeways with 6 laning, they will become barriers to gene flow. So the idea is then to create green infrastructure. So our research directly flows into showing mitigation strategies where you have India's first and the world's largest wildlife mitigation infrastructure on highway number 7, which connects Nagpur to Jabalpur. And under this highway, we have tigers crossing from one area to the other. So this is directly an outcome of research. Shifting gears, I will talk about a bird, the great Indian bustard, which almost became our national bird instead of the peacock. It was proposed by Dr. Salim Ali, but unfortunately the name bustard, if it is mispronounced, it can have a huge connotation. And therefore this bird was not selected as the national bird of India. And today this bird is in dire states. There are less than 130 individuals surviving on this planet, and a few populations in India. Just one actually in Rajasthan, in Jaisalmer, which has about 100 birds. The rest are 2 or 3 or 4 birds. In Maharashtra, there's a single female living in Sholapur. In Gujarat, there are 3 females living in Kutch. The primary reason for the decline of this bird has been collision with power lines. It's such a heavy bird that when it flies, it cannot see. And I've got a small film to show you on this, so I will not take much time. The film is self-explanatory. So what we have done is, as a policy against total extinction, as an insurance policy against total extinction, we have started a conservation breeding program where we harvest eggs from the wild, hatch them, and their progeny we hope to put back in the wild once the threats that caused their decline are addressed. So these birds are habituated and they'll be used for breeding. Okay, I'll just show you this film which explains how we do this.
Bustards are one of the heaviest flying birds, and they have no frontal vision. So when they fly, they do not expect barriers in the sky. And the modern power lines cause most of their deaths. As you can see, the bustard here has collided with the power line emanating from the windmills, which are the source of green energy. Considering the declining population of the great Indian bustard, the Ministry of Environment, Forests and Climate Change mandated the Wildlife Ministry of India to commence a conservation breeding program as an insurance against total extinction of the bustard in the wild. We're going to take you through the conservation breeding facility set up at Sam in the Desert National Park, a collaboration between the government of Rajasthan and the Wildlife Ministry of India, and a temporary facility has been set up at the Sam Dunes. The old guard quarters at Sam were transformed into a conservation breeding center with the help of the International Fund for Hobara Conservation. Scientists from IFHC Abu Dhabi helped us in designing it and setting the conservation center up at SAM. The facility here includes an incubator for incubating eggs which are secured from the wild. Subsequently, there is a hatchery in which the newborn chicks are kept, fed up to the age of about 10 months to about a year. The live feed facility is also maintained here. The area is made totally predator proof so that rodents or other carnivores like dogs and foxes cannot access the eggs or the chicks, and we can rear them with utmost security. The process commences with the location of breeding females that are nesting, and this requires a lot of field effort. Our field teams are well equipped. We had trained experts from IFHC who assisted our teams in locating females on nests. The regular movement of females within a localized area and a center homing place allows us to determine whether the female is nesting or is just wandering around on our foraging trips. So our team was able to locate several nests, and with the permission of the government of Rajasthan, we were able to secure 9 eggs this season and put them in the incubator for hatching. We have almost had 100% success rate till now, and there are 7 chicks which are born and reared in the conservation breeding sector at SAM. Once the egg is collected, it is cleaned and weighed. The transportation from the nest site to the center is done in a vehicle with a chick. The incubator is maintained
I'll just
at
stop
a
here.
constant temperature and humidity.
Since lack of time, I'll talk about the latest thing. So we now have 20 birds in captivity, and hopefully next year they will start breeding and their chicks will be put back in the wild, provided we have safe areas where these birds can live without power lines. The problem is the power lines. So we need at least about 300 to 400 square kilometer areas without power lines. The power lines have to be put underground so that these birds can survive. And that is a major tussle between power agencies, Ministry of Environment, and conservation needs of this bird. So recently, as you know, on the occasion of the birthday of the Prime Minister of India, Narendra Bhai Modi, the first cheetah were brought to India. And I'll talk a little about how this happened. So it is an effort which we've been working on since 2009, and it was fruitified this year under the Modi government. So the cheetah, the name itself is of Sanskrit origin. And unfortunately, ironically, we lost the cheetah in 1947. The last 3 cheetahs were shot in Chhattisgarh, in Sal forests. But if you look at the history of cheetah in India, you see cave paintings which are about 10 to 20,000 years old in Bhimbetka and in the Chhatrabhuj Nala in Madhya Pradesh. So the Neolithic people, cave dwellers at that point in time, knew the difference between a leopard and a cheetah, and you can see distinctly the body shape differences which come up in these cave paintings. Mr. Divya Bhanu Singh wrote up a book known as The End of a Trail, and he traced the history of cheetah in India. And as you can see, these are all the hunting records of cheetah in India, and you can see they range across the entire part of the subcontinent. This was the historical range of the animal, and you can see how it ranged into India and into Africa. Currently, only 9% of its historical range is occupied by the animal. The rest is all gone. They've been made extinct. These are the countries in which cheetah has been made extinct by human actions. And bringing back the cheetah in India not only serves our purpose of redressing the actions that we have taken on this planet, but also serves to the global objective of conserving the cheetah. So whenever we bring in a large carnivore into an ecosystem, they have a cascading effect on the different trophic levels which they affect. And it acts as an umbrella species as well. So with the cheetah, these are the conspecifics of the cheetah. The caracal, which is less than 100 animals in this country, the Indian wolf, the striped hyena, the Indian fox, the lesser florican and the great Indian bustards are sympatric. They live in the same habitats as the cheetah. So by conserving the cheetah, we create an umbrella which protects the entire biota. The threats that caused the extinction have been abated in our country. Today we have the economics, the science, and the political will to bring back this animal. So that's the idea of bringing it back. The first site in which we plan to reintroduce, we have reintroduced the cheetah, is in Kuno National Park in the state of Madhya Pradesh. This is a 750 square kilometer human-free national park embedded in a landscape which has good habitat for the cheetah of about 5,000 square kilometers. So there is enough space for the cheetah here. And there are many aspects which we need to consider before we bring in the animal. The most important is disease aspects, which will be familiar to you. Because when you bring in animals from Africa, just like, we had a lockdown for COVID, these animals can bring in novel pathogens into our country, which our carnivores and our wildlife is not exposed to. And that would cause catastrophic problems of epidemics possibly in our country. So we need to avoid that. So we screen these animals for diseases. There's a disease risk assessment done, and that is a published document. After that, after screening for diseases, we vaccinate them for diseases in India because they have no immunity against the diseases present in our country. So this has to be done, and there's a quarantine of 1 month in Africa and a quarantine of 1 month in India before that is done. Other concern is that conflict with humans. When you bring in a large carnivore, living with people can be very difficult. And the cheetah is one of the best carnivores to have in your neighborhood if you are going to have a carnivore, because there's not a single record of a wild cheetah killing a human being. So these people in this landscape have been living with tigers and leopards. Having a cheetah with them is going to be a piece of cake. Also, the cheetah, when the Prime Minister released the cheetah, the gates were open. The land prices, the real estate around this area escalated 100-fold. The price of land, which was 20,000 rupees a bigha, became 25 lakhs per bigha. So people have become rich overnight. And when communities profit from a conservation action, they are likely to support it. They know that it is because of this animal that we are rich today. And if we kill it, we are going to be in trouble. So I'll go to the process of how we did this. And you can see some of the glimpses of the cheetah. And I'll just show you a little bit of a documentation. So the cheetah were captured in Namibia and South Africa by helicopter, crated, given a anti-anxiety tranquilizer, so that when they are transported in this beautiful plane with the face of a tiger, they are not stressed. An MOU was signed with the government of Namibia. That's the Deputy Prime Minister of Namibia and our Minister of Environment. We had cheetahs brought in by helicopter, Army, Air Force helicopters, and in these crates, and then they were put into quarantine bomas. The Prime Minister released the first 3 animals on Indian soil after 70 years of their extinction. The cheetah has been a major evolutionary force in the subcontinent. The speed of the black buck and the chinkara are shaped by this species. Bringing back a large carnivore at the apex of the trophic level results in a cascading effect in the ecosystem. This has been eliminated by human actions. And today, we witness a bringing back of this evolutionary force. Hopefully, cheetahs like these two and many others from southern Africa will help establish viable populations in India in many of the reserves that we have. The threats that resulted in their extinction have been abated in our country now. We have created habitat which is suitable for these animals. The prey base is there, the legal system is in place, and the political will is also there. Lastly, I'd like to say that the fate of biodiversity is not in the hands of scientists, conservation, or managers, but on how society views and values it, what it is willing to pay, and how it motivates the political will to conserve it. So here you see the Prime Minister releasing one of my authored reports on the status of tigers. And I think today the political will is there. We need to make the most of it and make conservation happen. I'd like to acknowledge support from all these people, mostly my graduate students who have worked tirelessly to collect information and make this happen. Funding sources, the institute where I come from, and I worked for 30 years, the Wildlife Institute of India, and I thank the organizers of Wiroc for calling me here and inviting me. Thank you so much. Thank you, sir.